Okay. So now we're going to talk about pharmacology related to different CNS acting drugs, and one of those is muscle relaxants. So I just wanted to remind everyone, for the sake of anatomy, that you have nerves that intervene with those muscles. Okay, so that's how we get a lot of our movement, the interplay between nerves and muscles. And we have that whole, actin and myosin interplay to help with the movement of the muscles. So you could see how the nerves play an important role in our movement. And we have, different parts of the brain that can help control movement, right? We have the pyramidal tract, which helps with the intentional or our conscious movement, or the extrapyramidal tract, which is our unconscious body movements. And there's two really, really important terms that I want you to understand. There's muscle spasms and muscle spasticity, but they're different. So muscle spasms are usually caused by an injury from the musculoskeletal system, and it could be caused by a flood of sensory impulses, right? So just something's going on that causes a little spasm, right? But spasticity is a damage to the actual neurons in the CNS. And we see that in something like cerebral palsy, okay? So that is an example of a disorder that causes muscle spasticity. Now, I highlighted some of the important drugs that we're going to be talking about. So for children who have muscle spasticity, let's just say they have cerebral palsy, we would like to give them baclofen, which is a muscle relaxant. There's also metocarbamol, which is a drug of choice if the child has tetanus, which is muscle spasms. Dantrolene is used to treat upper motor neuron spasticity in children. Okay. We have these, I've never heard of these before, but they're called butylene toxins. They're also used for treatment of muscle spasticity. But remember, our elderly population is always at risk for like renal or hepatic issues. So a really good drug of choice for them, because they're centrally acting skeletal muscle relaxant, is carisoprodol. That's a really good drug of choice for an older adult patient, especially if they have hepatic or renal impairment. So we can give this safely to our older adult population. So I listed some of them here as examples of drugs that act centrally in the system. And these are muscle relaxants that treat spasticity. So if they're centrally acting, that means they work in the CNS. So we're thinking CNS depression. What these do is they destroy or lyse, which means destroy the spasm, okay? So we don't know exactly how it works, but we know that it affects the CNS's ability for the muscles to spasm. And in doing so, it destroys the spasm. So when do we use this? Well, if there's some sort of discomfort, if they have a musculoskeletal disorder, things like that. Now, remember, everything's absorbed pretty much and metabolized. All everything's in the liver, and most of the time it's excreted in the kidneys, so through urine. So we always need to watch out for any hepatic or renal dysfunction, right? Do they have any allergies or spasms that they're from rheumatic disorders, which are autoimmune disorders? No, that's not good, because then it's going to depress the CNS more, and that could affect the autoimmune disorder, since the body's already fighting against itself, and now we're giving them a medication that can help the body fight more against itself. Cautions, right? Epilepsy, seizures, right? Always seizures, you have to be really careful with giving any medications, especially CNS suppressants. That's the last thing, someone in a seizure might need, because it could affect all of their body systems. Cardiac dysfunction, why do we have to watch out for that? CNS depression might depress everything too much and cause cardiac problems, okay? And always pregnancy and lactation. Adverse effects of these centrally acting skeletal muscle relaxants. CNS suppression. So our priority is respiratory status. What's going on with their respirations? Are they hypotensive? Are they having arrhythmias? They could also have GI disturbances, and they could even have urinary frequency or enuresis or bedwetting. But remember, the priority here is respiratory. It affects the CNS, it causes CNS depression, which means we need to monitor our respiratory status. Drug-drug interactions, right? What should I teach a patient who is taking centrally acting skeletal muscle relaxants? Well, they should not take other CNS depressants like barbiturates, benzos, any of those, no narcotics, and definitely not alcohol because it's going to make it worse. Now, I don't know, like I said, if you do need to know these drugs, so if I were you, I would read them over, on your own. But fluoroxazone could discolor the urine, which would be a good teaching point to know if that's the medication you're giving to that patient. And tizidine is associated with liver toxicity and hypotension in some patients. But the main idea with these centrally acting skeletal muscle relaxants is that they help reduce spasticity, and a really bad adverse effect is that they might have CNS depression, okay? And which means it might depress everything a little too well. And a teaching point is to avoid anything that can cause further CNS depression, like alcohol, narcotics, benzos, barbiturates, things like that. Then we have direct acting skeletal muscle relaxants. So these do a little different. They're a little different than the other ones because the other ones were more or less working more in the CNS. These worked a little differently. Dantrolene, or those butylene toxins, they basically enter the muscle to prevent muscle contraction directly. Okay, it doesn't have to go to the CNS, that it actually works on the muscle. That's why they're called direct acting. So dantrolene interferes with the release of calcium from the muscles because we need calcium to keep those muscles to move. Whereas those toxins inhibit the release of acetylcholine. Now, acetylcholine is one of the hormones that, not hormones, it's a neurotransmitter, right, that we see in that parasympathetic system. So if we inhibit the release of acetylcholine, we could also help reduce muscle spasticity, okay? And like I said, these treat spasticity, okay, in those muscles. And an example of where we might give this is, like I said, cerebral palsy. Now, how do these work? Well, dantrolene is the most commonly seen one. And like I said, these interfere with the calcium that's released in those muscle tubules. But remember, you can't have the muscles working efficiently without the nerves. So there's always that nerve interplay. But with dantrolene, just know that it crosses the placenta, right? So that means we can't give it to pregnancy and we can't give it to lactating women. And with the toxins, they're not really absorbed systemically, and we don't really know how these drugs work. But the most common one is we see is dantrolene. Remember, dantrolene is the antidote for malignant hypothermia. So besides being a muscle relaxant, it helps with malignant hypothermia, which we're going to see as, a potential problem that comes from anesthesia or those anesthetic drugs. So dantrolene is the antidote. But regardless, right, any sort of medication, you never want to give it if they have a known allergy to it, right? Any sort of active hepatic disease, things like that. Now, cautions, I would read these over just to know, but with dantrolene, you have to be careful with our female patients, the patients who are over the age of 35, if they have a history of liver disease or previous dysfunction, respiratory depression, things like that, because you're going to see that in the adverse effects, because there is that muscle play and nerve play in that tubulus, because remember, we have the actin and myosin, and calcium is the electrolyte that controls the muscle contraction. So there is potential CNS depression. So that's why we want to be careful with all these. But with the toxins, you have to watch out with neuropathic disease, neuromuscular disorders, certain types, because we don't really know how this drug works. So we don't want to give this to anybody where they have extreme peripheral or neuro problems, okay? Because it's an interplay of the nerves and the muscles. So, dantrolene, CNS depression. So we know we have to watch out for respiratory status. For the butylene toxins, the most Problem that we see is a potential anaphylactic reaction, which means their throat might close, which means, you know, they could lose all airway support and potentially die. So those are our two things that we're really, really watching out for. So you could think, okay, with these direct acting skeletal muscle relaxants, like the centrally acting, I have to really watch out for respiratory complications. Any questions? Okay, so no questions. Then the next thing we're going to talk about is general and local anesthetic agents. So for anesthesia, we have two different types. We have general anesthesia and we have local anesthesia. So general means that it can go pretty much everywhere. As soon as you take that anesthesia, it's going to affect everything, okay? And it causes loss of consciousness, um, helps you forget like the procedure even happened, and even helps with reducing pain, okay? And loss of reflexes because they're CNS depressants. Now, local anesthesia is used for a specific area to numb something very specific. That's why it's called local, right? Like a lidocaine patch is a local anesthetic because it can cause numbness and reduce pain in a specific area. That's why it's considered local. Whereas general is that I don't know if anyone's ever had a wisdom tooth surgery or knows someone who has. I had one, and you give that like laughing gas, to like knock them out and like let them go through this whole process. Um, that is an example of a general anesthetic. So, what are the goals of anesthesia? Like we said already, pain loss. They don't have pain. They don't know what's going on. And they lose memory that the event or the procedure even happened. We don't want them to remember anything, okay? We just want to be able to do the surgery and, have them have no pain and not be aware of what's going on. So, risk factors associated with general anesthesia. CNS factors, right? Central nervous system depressants. These are what they are. Cardiovascular factors, respiratory factors, because these are going to depress those systems, especially. Renal and hepatic function, always a problem because, our liver is how we metabolize all of our drugs. So, what are some agents involved in anesthesia, right? We can give some preoperative medications, right? Like maybe preoperative pain, right? An example of a sedative hypnotic might be a barbiturate to knock them out. That could be used in adjunction with anesthesia. An antiemetic to prevent any nausea and vomiting, especially ones like midazolam, which we'll get into, that can cause nausea and vomiting. Antihistamines to reduce any sort of inflammation, and even opioids for pain. So, here are the stages of anesthesia. The first stage is the pain phase, okay? They're going to be in a little bit of pain. Then the pain's going to go away. Then they're going to go into an excitement phase, meaning that the sympathetic and CNS system is going to realize that you're trying to knock me out. You're trying to put me under, and your body's going to try to fight it. It's going to try to get really, really out of this sedative feeling. But we give a little bit more anesthesia, and then we get them into stage 3 where they get the surgical anesthesia. They're knocked out, they have no pain, they're not being combative and trying to get out of it. They're calm and you're able to do your thing. But the problem with being in with anesthetic drugs is that too much can cause paralysis and they could die. So we never want to get to stage 4. We always want to be in stages 1 to 3. We want to get to 3 and then recover from 3. This is just a summary of how it works, right? So in stage 1, we're losing some of that pain, right? The pain that they had, that they're getting, is going to be lost from whatever the surgical procedure is trying to do. We're going to have that competitive excitement where basically they're really stimulated sympathetically and they're trying to get out of it. And we're like, no, you're not going to get out of it. We're going to give them a little bit more. And then they're finally relaxed and you're able to do the surgery. But if it gets to stage 4, it can lead to death. So basically, some ways that we also administer general anesthetics is through this process of induction, maintenance, and recovery. So induction is all the way until stage 3, where we start giving the anesthesia. Maintenance is where we start giving it in stage 3, meaning to keep the anesthesia in the patient's body so that they can stay in this, loss of environmental stimuli, so they're not knowing what's going on. They stay in that sort of feeling until the surgery is complete. Once it's complete, they'll stop giving the maintenance anesthesia and they'll go into recovery and they'll regain consciousness. A great anesthetic for children, that's a general anesthetic, is propofol. We can use that in short procedures in children older than 3. I just wanted to point that out as one of the anesthetics that we can give. But there's types of general anesthetics. Remember, our goal for general anesthetics is to reduce pain, to lose consciousness of the surgical procedure, and not remember the surgical procedure. And we have barbiturates, like I remember I mentioned, what was that? Phenobarbital, thiopental, methotrexate, right? All of those barbiturates are, besides being anti-anxiety medications, are anesthetics. Non-barbiturate anesthetics, gas anesthetics, and volatile liquids. Both of those are going to be inhaled. So let's first look at our barbiturate anesthetics. We have methotrexate, which is usually used for short procedures. That's why I was emphasizing in my lecture on barbiturates about the different types of categories for barbiturates, which ones act short acting, which ones are long acting, which ones are short, intermediate, because if they're used for anesthesia, that becomes important. So methotrexate is usually used as a ultra short acting, so very, very, very quick procedures, okay? It doesn't last long. You have a rapid onset, and the recovery period is in 3 to 4 minutes. It works really quickly and leaves really quickly, okay? So it's usually used in adjunct with general anesthesia to produce some sort of hypnotic state. Remember, that's like a sleepy state, and to help reduce pain. So I don't know why this slide is blurry, but here's the problem. These are CNS depressants. So for all of these anesthetic drugs, especially these general anesthetics, you need to have resuscitative drugs and equipment on standby. They need to be at the bedside, okay? Because they can have CNS depression that gets too bad and they can lose, all airway function, okay? So our priority is maintaining airway. Next thing is that we can't give this to a patient who has a hypersensitivity or an allergy to barbiturates and is pregnant or lactating. Those are some of the things that I want to point out. But remember, priority, resuscitative, and ventilation at the bedside. Because of this adverse effect of potential CNS depression, and it might do it too well and suppress respirations. Now, nausea and vomiting is something that you might see after recovery. That's why we said adjuncts to surgery or general anesthesia include antiemetics, right? Like Reglan or aldosterone, metoclopramide, things like that. So what are drug-drug interactions? Once again, any other CNS depressants, right? So barbiturates, we're not going to take that with the benzos and anything like that. No opioids, no alcohol, because they're also CNS depressants. And that is not good. And remember, physical dependence with barbiturates regularly, right? That's just something I want to remind you of, right? So that's why these are anesthetic drugs, right? They're using this one-time deal. It's not a regular barbiturate where we're going to have to watch out for that physical, psychological dependence that they could tolerate or obtain from using this anesthetic. Then we have non-barbiturate anesthetics like ethimidate, ketamine, midazolam, and propofol. So non-barbiturates meaning, okay, they work in that like GABA system, so they are working in the CNS, but not in the same way barbiturates are. So midazolam, it's used to produce amnesia or sedation for many procedures. It's very quick, and it could provide continuous sedation for an intubated or mechanically ventilated patient. I had an example where I had a patient who was very combative because they had uh, a slow developmental state despite being an adult. They could not speak, they were nonverbal, and we use midazolam to keep this patient in a sedative state as they mechanically intubated them. Okay, so etomidate is another general anesthetic that we can use to sedate patients also if they have mechanical ventilation, which means right airway could be a problem, right? So airway, resuscitative equipment at bedside. Ketamine could be really good for patients when cardiac depression is dangerous. So if they have a cardiac issue, ketamine might be the drug of choice for this for the anesthetic to use. And propofol is used for short procedures because it works really quickly. Now, we're going to see adverse effects are respiratory depression and CNS suppression, so mechanical ventilation and being ready to intubate at the bedside. Ethimidate, also a quick recovery, but it can cause like monoclonic tonic, like rigidity and stiffness. So we have to watch out for that, and nausea and vomiting. Ketamine can cause hallucinations, which means, sensory things that they might hear or see things that are not really there. Propofol can cause local burning on injection, bradycardia, and hypotension, right? So with these, it could even cause pulmonary edema. So we really want to watch our vitals and auscultate the lungs. But with all of these, there's always that chance of respiratory depression, so mechanical resuscitative equipment at the bedside. Now, interactions from midazolam include any other inhaled anesthetics. Remember, it could further CNS suppression, opioids or alcohol, even propofol. And for ketamine, it's those neuromuscular junction blockers, which we'll get into a little bit. Just remember with ketamine, we don't want to give these drugs with them. Okay, now we have anesthetic gases. These are the ones that we inhale. They're very flammable. They could have toxic effects. Remember, if they're working in the lungs, right? Potential respiratory problem because you're inhaling them, which means they're going directly into the alveoli of the lungs. Common one is nitric oxide or like laughing gas, okay? So what's really good about nitrous oxide, remember it's a general anesthetic, is that it's very potent analgesic, meaning it helps reduce pain, but it doesn't cause muscle relaxation. So we see this in dental surgery. It has a rapid onset and a rapid recovery. Now, always with gases, this one and the next gases of anesthetics I already talked about called volatile liquids, we do not mix gases with gases. Remember, problem with CNS suppression. It can block the reuptake of oxygen after surgery, which means we need to have O2 or oxygen readily available at the bedside and, potential ventilation equipment, okay? No pregnancy or breastfeeding patients, especially they should wait 4 hours before feeding the baby because it is respiratory, so it's going to be able to be coming out of the lungs. So it's not going to last as long and it's not going to have like as much systemic circulation as the other drugs would, but they should wait a couple of hours after the surgery of using these anesthetic gas before they breastfeed their baby. Okay, so what are other adverse effects, right? There's, yes, all of these other adverse effects, but if you had to pick which one is the problem, it's that they could have pneumothorax or collapse of the lung, where there's air and stuff getting into the lungs. This is the priority. This is a respiratory problem. So mechanical ventilation at the bedside and drug-drug interactions, CNS suppressants, because these are CNS suppressants. Volatile liquids, another type of inhaled anesthetic that is also a CNS suppressant, and they all end in fluorine. So desflurane, isoflurane, sevoflurane. Okay, that should really help. So here's the important points. Remember I said we talked about induction, maintenance, and recovery. So sevoflurane is an induction agent. That's the first thing that we give to knock them out, to get them to stage 3. Isoflurane is a maintenance drug. That's what we keep giving them to keep them under this hypnotic state. And desflurane is typically used in an outpatient surgery. So these are all pretty quick. They have a rapid recovery. And as soon as you give it, these can work within 2 minutes. So all of these drugs work really quickly and they're cleared through the lungs. So we really, really have to watch out for what? Respiratory problems. And if the patients already have respiratory problems because these are cleared in the lungs, they should not be getting volatile liquids, okay? We don't want to give this to kids. They have a risk for hyperthermia. Remember, we said malignant hyperthermia is what we get from anesthetic drugs, right? So we give dantrolene as the antidote for malignant hyperthermia. And we talked about dantrolene already as one of those spasticity drugs. But once again, we have a risk for hyperthermia. So we need to know, hey, we might need to give dantrolene if they have malignant hyperthermia. And no pregnancy and lactation. Always a rule of thumb. So remember, respiratory is our priority. But sevoflurane doesn't have as many adverse effects. Isoflurane more causes hypotension and hypercapnia, but remember, too much CO2 can also be a problem, okay? And desflurane causes respiratory reactions, but regardless, these are still seen as suppressants, so we need respiratory, mechanical, ventilation equipment at the bedside, and always drug-drug interactions seen as suppressants. That's just going to be a rule of thumb forever. Now, like I said, these are all centrally nervous system acting, so they cause suppression of almost everything, okay? Which causes respiratory suppression potentially, cardiovascular suppression like hypotension and slowed heart rate, GI effects of slowed peristalsis, which means decreased activity and leading to potential nausea and vomiting. Local anesthetics, like I said, they focus on numbing a certain particular area, right? Like I talked about those lidocaine patches. Now, what should we tell someone preoperative if they're going to get a general anesthetic before surgery? One, let them know what happens with the anesthetic. You know that there's always the risk of respiratory depression, right? Medications that might be used preoperatively in conjunction with that, like maybe an antiemetic, pain meds, things like that. What this medication will do, right? How they're going to maintain the patient's safety and how they're going to feel during their recovery, right? Are they going to they might vomit, right? That's a common side effect of anesthetic drugs that they might vomit after, okay? And any signs and symptoms to report post-surgery if they see them. Post-surgery, I always see this even for myself when I've dropped off my own parents to surgeries. It's just that you never let them drive or operate any machinery because all of anesthetics are seen as suppressants, so they might be sluggish and their coordination is not good, so they cannot leave the hospital by themselves. Someone needs to get them, pick them up, bring them home. And also we should not let them sign any legal documents for 24 hours because remember, they're sluggish, they're slurred, and they might be a little confused coming out of the anesthetics. Is there any questions? No. Okay. So next we're going to talk about local anesthesia. This means, like I said, it affects a specific spot, okay? Some particular area of the body. Like I said, lidocaine patch, you can put it on the back and it'll decrease the pain in that particular area. So these are nerve blockers. They help block the signals of nerves, which is what is causing the pain. All of them end in cane. So the local anesthetics, lidocaine, methadone, prilocaine, all of these, you're definitely going to be able to recognize a local anesthetic very easily. But what do they do? Well, actually, these affect those sodium ions. So sodium is another one that affects the permeability of nerve membranes. So we have to watch out for electrolyte problems, especially if they're taking one of these local anesthetics, because they affect sodium. So, and these, by doing so, they interrupt the production and conduction of nerve impulses. How can we give it to them? Well, we might give it to them if they have anesthesia and infiltration anesthesia, meaning we give them an IV or something in a specific area, right? If they have nerve block, if they need spinal anesthesia, we might give one of these, right, to numb a certain area, or relief of pain, like I said before, like a lidocaine patch on the back if they have a lot of pain there. So, I don't really know which ones are esters and which ones are amides. So I would say please like look at them. But the main point is that remember, this is a type of CNS depressant, okay? Even though it doesn't work systemically, it does work locally, okay? So shock, heart block, okay, pregnancy, all of these would be a problem. Allergies, right? Because CNS depression can make these worse. Shock is when your organs shut down, right? So all they need is CNS depressive drugs to shut down those organs even more. Adverse effects relate to CNS effects, cardiovascular effects. That's our priority, right? Looking at respiratory depression, right? Cardiovascular effect. Are they having arrhythmias? Things like that. Now, drug-drug interactions will include acetylcholine and epinephrine, because epinephrine is going to stimulate everything. Not really good. We don't need a sympathetic acting drug when we're trying to suppress. And acetylcholine doesn't really interact well with a lot of things. It's also a part of those drugs that helps relax muscles. So we're not going to give them a medication that's going to relax the muscles when CNS depressive effects can do that already. Any questions? No. Okay. So the next thing that we have, the last thing that we're talking about is neuromuscular junction blocking agents. The neuromuscular junction is where the motor neuron communicates with those skeletal muscle fibers to cause muscle contraction. That's why I said muscles and nerves, really important. We have that sliding filament there. Think back to anatomy and physiology, right? The actin and myosin filaments go over each other, move, and that's how we get muscle contraction, okay? So we have this sort of balance between excitatory and inhibitory impulses from muscle tone. Okay, we're going to work on these mechanisms very differently. So this is just what I was talking about, that sarcomere, right? Those myosin and actin filaments crossing over to cause a contraction. That's how we get movement. Now, one thing that I want to talk about is that neuromuscular junction blocking agents are not very good for children, so just be really, really careful with them. And acetylcholine is only indicated if there's an emergency for intubation. So we don't really like acetylcholine, and we'll get into why. So we have two different categories of these neuromuscular junction blocking agents. We have non-depolarizing. These act as antagonists to acetylcholine. This prevents depolarization of the muscles, which causes muscle paralysis. So depolarization basically means, right, that the actions of the muscles are going to increase. So if depolarization means, hey, I'm going to stimulate the nerves so that they can stimulate the muscles to move, we antagonize acetylcholine, which is going to prevent depolarization. We have depolarizing, which act as an agonist to acetylcholine, because acetylcholine also acts as a parasympathetic stimulant. So we prevent repolarizing, right? So what can happen, right, if we have this interplay between depolarization or things go up and repolarization where things start to relax, right? We don't want the cycle to restart. So if we prevent it from repolarizing, we can actually keep the sodium channels open, and it can really help with some of the problems that we're going to talk about. So these act on the neuromuscular junction, and they work with the acetylcholine, and the only drug is acetylcholine. And the non-depolarizings antagonize acetylcholine, okay? And the goal is to cause like muscle paralysis. And we're going to see why. So these are the sites, as an example of how these drugs work at the neuromuscular junction. So the acetylcholine is going to prevent stimulation. The drugs are going to occupy the acetylcholine receptors, especially if they're the non-depolarizing ones. They're going to prevent the action of acetylcholine from stimulating the site, which is going to prevent the muscles from moving. Acetylcholine, which is that depolarizing drug, which acts, meaning it agonizes or mimics acetylcholine, it can cause stimulation and muscle contraction. So depolarizing ones, or the only one, acetylcholine, is going to cause muscle contraction, whereas non-depolarizing neuromuscular junction blockers, meaning the ones that antagonize, they fight for the acetylcholine receptor, so they stop acetylcholine, and in doing so, they cause muscle paralysis. All of these end in curium or cronium. So this is just the onset and duration. So you can see that they work really quickly and they last pretty much very long, except for acetylcholine, which is which is a depolarizing neuromuscular junction blocker, and it agonizes that acetylcholine, which causes muscle stimulation and contraction. So non-depolarizing, we're causing muscle paralysis, and they all end in curium or cronium. What does it do? Like I said, it prevents muscle movement. So it can be really good as an adjunct during general anesthesia, right, to help reduce muscle movements that can interfere with the procedure. If this is causing muscle paralysis, this is very great for patients who are getting mechanical intubation, right? If we're going to intubate them and we don't want them to fight us, we don't want to get resistance from them, because then it's going to make it much harder and we could damage, the esophagus and the trachea. So this is really good for someone who might be very resistive and it has no gag reflex. So it makes it easier for us to intubate them. We can use these because they cause muscle paralysis for endoscopic procedures where they put tubes down your throat. It could cause muscle relaxation, and remember, it prevents that gag reflex. It could even facilitate electroconvulsive therapy, where when the skeletal muscles start contracting intensely, the result could be that the shock could cause the patient to break bones or other injuries. So if we give them a non-depolarizing neuromuscular junction blocker before that, it could help reduce any potential injuries, because that electrical stimulation from the electroconvulsive therapy can be too much and it can hurt them. So remember, we said these antagonize. So these do not mimic acetylcholine. Acetylcholine is a receptor site like those muscarinic and nicotinic receptors, but these are on the nicotinic receptors, right? So those parasympathetic, when we were talking about cholinergic drugs, we were talking about muscarinic receptors. We're talking about nicotinic receptors, which focus on just the muscle. So these occupy that muscular cholinergic receptor site. It doesn't stimulate it, which causes muscle paralysis, okay? So it's excreted in the urine. And remember, it's always metabolized by the liver, so we have to watch out for renal or hepatic disease. Now, myasthenia gravis is a muscular autoimmune disorder where the muscles start to slow down. We usually give cholinergic drugs that act on the muscarinic, but these work on the nicotinic and actually block the muscles and make them slow down even more, which would not be good for someone who has myasthenia gravis. We're also looking at allergies and pregnancy as a contraindication. Be careful with pulmonary or cardiovascular dysfunction because it causes muscle paralysis. It could slow down those pulmonary and cardiovascular muscles very, very easily. It's not a CNS depressant, but it causes muscle paralysis. Remember, our heart, our lungs are muscles. We could have altered fluid and electrolyte imbalance and things like that. So, what's an adverse effect associated with muscle paralysis? Well, decreased respiration, bronchospasms, and apnea, or breathing to stop. So mechanical ventilation, ready at bedside. Histamine, it can cause an inflammatory response, which can cause the obstruction and bronchospasm. Very important. It can cause hypotension and cardiac arrhythmias. So we got to watch out for our cardiac and respiratory status, as well as, GI dysfunction, pressure ulcers, and it can cause, we said before, potential electrolyte problems. So we should watch for hyperkalemia, because that could also further cardiac arrhythmias. Now, what should we watch out for non-depolarizing? Remember, we're causing muscle paralysis, general aesthetics. Why? Because it can cause CNS depression and make it even worse. Remember, these are not CNS depressing drugs, but they both work in a way of depressing either the nerve action, which is a general anesthetics, which can cause respiratory depression, and these drugs cause muscle paralysis, the muscles to basically stop moving. So that's how they can both cause respiratory, depression. Aminoglycoside antibiotics. Aminoglycoside antibiotics are highly toxic and they affect pulmonary, cardiac. So that is not good. They can cause pulmonary toxicity. That's why, and cardiac toxicity, which is why we don't want to give these drugs in conjunction to that. Choline esterase inhibitors. Okay, those are like the opposites of these drugs. So we don't want to give something that's going to cause a paradoxical effect, or else the drug's not going to really work. Exitines, right? Like theophylline, those respiratory medications, not good because those are also very toxic. And alkaline solutions like barbiturates, CNS depressants. Herbs like drug herb like reactions can be valerian root because it calms and helps you sleep, melatonin, and kava. And kava can be toxic to the liver. So succinylcholine is a depolarizing neuromuscular junction blocker. This agonizes acetylcholine receptors, okay? So this causes muscle contraction and stimulation. So then it causes flaccid paralysis. So you're going to get a quick stimulation and muscle contraction, and then it's going to make the muscles weak. Not completely paralyzed, but just weak. This usually works in a minute and it lasts 10 to 12 minutes. Okay, so this is for something like a really, really quick procedure. And this is the only depolarizing neuromuscular junction blocker. So, contraindications, you cannot give this to kids. It's really not good for kids. We really don't want to give succinylcholine for kids. Malignant hypothermia, because it can cause it or make it worse. Cautions include fractures, narrow angle glaucoma, or eye injuries. Remember, right, we're causing muscle contraction and then potential weakness. So that would not be good for the eye muscles. Paraplegia, right, or spinal cord injuries because it's going to cause stimulation and then flaccidity. And, for these patients, it might not act or react the same way and it could cause injuries. And things like that. But the main thing that I want you to know is that it can cause malignant hypothermia. We don't want to give it to kids, and that these agonize those acetylcholine receptors because they're depolarizing. Succinylcholine is depolarizing, so it causes stimulation and contraction, and then it causes flaccidity or weakness in the muscles. So adverse effects are very similar to what we spoke about before, right? So potential respiratory complications, always. And this malignant hypothermia is something we have to really, really watch out for, and we give them dantrolene if that happens. Drug-drug interactions, all of those CNS acting drugs can potentiate or make these drugs worse because remember, it starts off with stimulation and then it becomes weak. So all of those other drugs can further exacerbate respiratory depression or respiratory problems. Is there any questions?